Now we start the program with IMA prayer by Dr. Chitra, who is a dermatologist from Balaja Government Headquarters Hospital.
Good evening, everyone. IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the king beyond every greed and lure.
Thank you, Doctor. Now over to the physician prayer by Dr. Shanti of Bell Hospital. Dr. Shanti? Madam? Physician prayer, ma?
Inform பண்ணலையே மேடம்.
இல்ல மேடம், சாந்தி பெல் ஹாஸ்பிட்டல் மேடம்.
ஓகே ஓகே.
டாக்டர் சாந்தி இருக்கீங்களா? டாக்டர் சாந்தி from Bell Hospital. Dr. Shanti, are you here, ma? Dr. Shanti? Now the flag salutation by Dr. Usha Nandini, madam. She is the gynecologist and medical superintendent of Government Headquarters Hospital, Balaja. Madam.
Thank you, madam. Good evening, one and all. Flag salutation. We, the members of IMA, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of the national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA. Thank you, everyone.
Thank you, madam. Thank you.
Thank you.
Over to the welcome speech by President. Good evening, doctors. On behalf of office bearers and members of IMA Ranipet, I extend my warm welcome to each one of you doctors who are attending this online CME, sparing your valuable time on a Sunday evening. I take great pleasure to extend my hearty welcome to our chief guest today, Dr. Manimaran sir, who is our Deputy Director of Health Services of Ranipet District. Thank you, sir, for accepting our invitation over a short notice. We are honored to have you here, sir. Let me share a few words about sir. He is here in our district for the past 4 months. He's a native of Thiruvarur, settled in Chennai. He did his MBBS from Tanjavur Medical College and DPH from MMC, and has worked as tutor in Kanyakumari, Vellore, and Madras Medical Colleges, and as an associate professor at Stanley Medical College, as a health officer at Ambattur, and as DDHS at Arandangi, Pudukottai, Kovilpatti, Thuthukudi, and now back to our district, Ranipet district. And his wife is also a doctor, now a zonal medical officer at Chennai Corporation. He is blessed with 3 children. 2 of them are doctors and 1 child is in the 12th standard. We are happy that he is with us as chief guest. Welcome, sir. I extend my hearty warm welcome to our vibrant team of speakers from Department of Pediatrics, CMC, Vellore. They are well known to all of us. Dr. Walson Philip Varghese, Professor, Pediatric Infectious Diseases, Unit 3, CMC. Dr. Satish Kumar, Professor and Head Pediatric Unit 2 CMC. Dr. Winsley Rose, Professor of Unit 2 Pediatrics CMC. Dr. Ebo Jacob James, Professor and in charge of Pediatric ICU CMC. I'm very thankful to all of them for accepting our invitation in spite of the hectic schedule this whole week and at a very short notice. Welcome you all, sir, and we are very happy and honored to have you all here, sir, this evening. And our moderator, Dr. Ebo, sir, will introduce all the speakers to us before the session starts. I extend my warm welcome to our Honorary Secretary, Dr. Saravanan, sir, Dr. Finance Secretary, Dr. Srinivasan, our past Secretary, Dr. Parameshwaran, sir, Dr. Usha Nandini, madam, who is our Women's Wing Secretary, and I'm happy to share with you that she is now the Medical Superintendent of Government Headquarters Hospital, Balaja. I now welcome all office bearers and members of IMA Ranipet for sparing their valuable time. I'm happy to welcome all doctors from different places who have accepted our invite to be with us this evening to enjoy the academic feast. I also express my gratitude to Mr. Prem, who is a Maths teacher and is giving us the technical guidance for this program. Once again, thanks to all of you. Please feel free to interact with our speakers at the end of the session, and they are happy to share their knowledge with us. Now it's time for our Secretary's report. Sir, Dr. Saravanan, sir, are you back, sir? Dr. Saravanan, sir? Actually, Dr. Saravanan, sir, our secretary, he said he has got some university meeting between 4 and 6. So if possible, he said he'll join. Let me also share the secretary's report. Last CME was conducted by 21st March, on 21st March, along with Women's Day celebrations. After that, 30th March, we office bearers went in person to felicitate the 3 outstanding women we were for Women's Day. Dr. Guma Patsadi, Director of Tirumala Mission Trust, Dr. Sulochana, our senior most lady medical officer in IMA, and the DSP of Ranipet district, Mrs. K.T. Purani. And in April, no activities. On 24th May, we conducted a blood donation camp at Tirumala Mission Hospital. There was a good response in spite of the COVID situation. From state IME, we have been receiving letters to collect COVID funds to help the government kindly contribute. And recently, our IMA protest day for violence against doctors was submitted. And we submitted a memorandum to our district collector on 18th June. Now, our finance secretary, Dr. Srinivasan, will share his report. Dr. Srinivasan?
Yes, ma'am. Yeah, good evening to all. First of all, I welcome you one and all for this CME program. I welcome all the members and especially welcome our guest of honor, Dr. V. Manimaran sir, and our speakers, Dr. Walson Philip Varghese sir, Dr. T. Satish Kumar sir, Dr. Winsley Rose, and Dr. Ebor Jacob sir. I welcome you all. Thank you for accepting our invitation for this meeting. And as a finance secretary, there is not much as of before and now. Finances remain the same, and there is no much differences in the finance part. And regarding IMA CME accreditation, we have got accreditation certificate just this morning. So we'll be conducting CME programs with CME credit points from next month onwards. Every CME program will have credit points. And our IMA branch registration and PAN card is still pending. Due to COVID reasons, the register is not available. Other than that, there is nothing much of the update. Yeah. Thank you one and all for joining us. Thank you all.
Thank you, Dr. Srinivasan. And at this point, I should congratulate you for taking all the efforts to get this accreditation for our meetings. By next meeting, for probably it should be active.
Yes,
because
ma'am.
we inform 10 days in advance, I think, before the meeting. But I think we got it only today.
Yes, sure.
Now, before we start our long-awaited academic session, and before I hand over to our moderator, Dr. Ebor Jacob James, it's my duty to introduce our moderator to you all. Dr. Ebor Jacob James is at present Professor, Pediatric Critical Care, CMC Hospital, Vellore. He is a Fellow of Indian Academy of Pediatrics. He's also a Fellow of the Indian College of Critical Care Medicine. He's also the Vice President of PediStars, that is Pediatric Stimulation in Training and Research Society of India. He's a EV member, IAP Intensive Care Chapter, College Council, and he's also the South Zone Coordinator for TIPS and IAP Transport Module. And he has received IAP Active Pediatrician Award 2017. And he's also the Regional Faculty for American Heart Association. And he's a reviewer also in Indian Pediatrics, Archives of Disease in Childhood, and Indian Journal of Critical Care Medicine. He's also an ICMR expert in pediatric critical care. He's also the examiner for DM and FNB, Pediatric Intensive Care, and he has around 30 publications. And he has also authored chapters in textbooks for pediatric critical care, IAP ALS book, IAP protocol, PICU, and IAP specialty textbooks on pediatric infectious disease. We are greatly honored to have you here as a moderator, sir. And over to you, sir. Dr. Ebor, sir, for the scientific session.
Thank you. Thank you, Dr. Geeta Lysander. Good evening to you all. Shall I just share my screen?
Yes, sir. Yes.
Good evening again, and thank you, Dr. Geeta Lysander, for the kind words. And we bring greetings from the Department of Child Health and Pediatrics at Christian Medical College, Vellore, and to talk about the updates in the COVID-19 children. And it's my pleasure and privilege to introduce my colleagues and friends, Dr. Valsan Philip Verghese, who's done fellowship in pediatric infectious disease after his pediatric training at University of Alberta in Canada. He's a professor of pediatrics and professor of pediatric infectious disease at CMC. He was the former head of pediatric unit 3 and additional deputy chair of hospital infection control committee at CMC Vellore and faculty at the clinical epidemiology unit at CMC. He has got a lot of positions and fellowships to his credit, and his publications, more than 60 research publications and chapters and publications in HIV care. And his research activities are mostly in vaccine trials, vaccine preventable disease, and biomarker studies. He'll be talking about the overview of COVID in children, manifestations, diagnosis, and management. The second speaker, Dr. Satish Kumar, is a professor of pediatrics and consultant pediatric rheumatologist, who has got his rheumatology fellowship from Sick Kids Hospital for Sick Children in the University of Toronto. And he's also the editor of International Journal of, assistant editor of International Journal of Rheumatic Diseases and Indian Journal of Rheumatology. Reviewer of many journals, and he's got more than 95 publications. His areas of interest are pediatric lupus, juvenile idiopathic arthritis, pediatric uveitis. He will be talking on the much talked about topic, the MIS-C, multi-system inflammatory syndrome in children. And the next speaker is Dr. Winsley Rose. He is a professor of pediatrics and pediatric infectious disease physician. And he's got his fellowship from the University of Toronto, from the Hospital Sick Kids. And his areas of interest, he's got many publications, and his area of interest in vaccine preventable diseases, vaccine trials, and rickettsial diseases. He will be talking about preventive strategies of about COVID-19 in children. And the topic we know, that's mainly about the impact of COVID-19 in children. So just before giving over to Dr. Walson for the first talk, we know there's the burden of COVID-19 in children in India. It's not very much affected. This is from the National Center of Disease Control. Less than 10 years, it was only 2.5 over 4% about hospitalized children, and 40% of who died of comorbidities. And there is not much change between the two waves. This is from our Vellore, CMC Vellore data, and I understand Dr. Winsley Rose will elaborate that is not much similar to both the waves. And this is what is the red one is the intensive care admissions. You can see there is not much, about 12 to 14% of them got in ICU admission. And the last one is the missing. How many people have admitted both the waves, the purple color one. And there's a mortality overall above the hospitalized children is about 1%, and those who are admitted into ICU is about 9 to 10%. And all of them, or I can say at least 95% of them had comorbidities associated, and which probably lead on to the death of the children. And the MIS-C, we've seen in the first wave as well. And in the second wave till now, 20 I'm speaking, probably we have got 32 children of MIS-C. That is the one thing we have to be highlighting mostly, probably today's talk after the overview and how we can prevent. And this MIS-C has different phenotypes. We have about 7 to 8 phenotypes. These are the children we have differentiated and categorized them based on our own protocol. Yes, Ministry of Health has come 2 days ago, the protocol, and many protocols have been available, even Indian Academy of Pediatrics protocols. And this protocol also, Sadish will talk about this. And we followed this, and we have categorized them clinically into this phenotypes, and that's what our experience in the MIS-C. And so I'll just, the talk will be about all these points, which I'm just putting here, information as a medical practitioner from IMA. So we are talking about the third wave, probably it might affect the children. So what can we do? So that is one of the probable message which all will be giving to you. So how we can circulate the information about how to prevent that, whether MIS-C can be reportable in some of the states is yes. How to avoid overdiagnosing and underdiagnosing. How can we have an early identification tool, mainly to identify the danger signs as we see in IMNCA, which is a very old, which any pediatricians or medical practitioners are aware of that. So with this words of introduction, I'll hand over to Dr. Wilson Varghese to talk on his topic on clinical manifestations, diagnosis and management of COVID. Over to you, Dr. Wilson.
Thank you, Dr. Ebor. Thank you to IMA Ranipet and Dr. Geeta Lysander and Dr. Saravanan for the invitation. I will just start by sharing my screen. Okay, is my screen visible?
Yes, sir.
Thank you. So, yeah, I don't need to speak anything more about myself. Dr. Ebor has been very kind to introduce me. And SARS-CoV-2, as we all know, is caused by, a coronavirus, and it causes COVID-19. We don't need to talk more about that. But what is of interest now, at least what we are seeing daily in the newspapers, are the mutations and the variants of concern. Now, why are we interested in the mutations? There are several mutations, but a lot of them take place in the receptor binding domain of the virus's spike protein, and this leads to increased transmissibility and escape from neutralizing antibody. So the variants of concern that have been described, the first one is the alpha variant, which was first described from Kent, UK. It made up about 90% of Punjab and Delhi samples between January to March. By April, it was replaced by the Delta variant. Beta first isolated in South Africa, Gamma from Brazil, and then the Delta variant, which was seen first isolated in Maharashtra, made up 61% of Maharashtra samples in March, and is now the predominant strain in India that has driven the second wave, with more than 80% of samples in UP and 70% of samples in Gujarat and Puducherry. So now the question is, when you have an increased transmissible variant, how does that affect children? Does that mean it is going to be has that been a more severe second wave? Is it likely to be a more severe third wave? So this is data from the first wave. What you can find is that children were disproportionately less affected. In China, they made up 17% of the population, but only 2% of cases. In the US, 22% of the population, only 1.7% of the cases. And then when you look at mortality, if you look at case fatality, very, very similar across countries, 0.2% from China, 0.2% from the US, and also even from Tamil Nadu last year, 0.2% case fatality. This is compared to anywhere between 15 to 30% in adults over 75 years of age. So what about the second wave? This is data, the middle one is data from Maharashtra last year with the first wave. This is data from Maharashtra, more than 28 lakh cases between January and March. And when you compare the proportions of age groups, one thing is very evident that the proportions overall have not changed. In fact, they are very, very similar. The second thing that is evident is when you look at children, children make up approximately 9% of the overall. And how does that compare with the 2% we heard about from China? One of the things that's different from India is we have a younger population. The population proportion that is in the under 20 age group is 35%. So it's not surprising that we have a higher percentage, but again, proportionately much less. Now, because of the increased transmissibility, there has definitely been an increased number of cases in the second wave. This is data from Velocity. The whole of last year diagnosed cases, 11,000. This is all ages, not children. And in 3 months in this year alone, March to May, it crossed that number. So definitely absolute numbers have gone up. Proportion of pediatric infections, I showed you that in January to March, it was 9% in Maharashtra. April, it was 8%. And 7% in Maharashtra in November. Proportion of pediatric infections in the second wave have stayed the same and the mortality has not gone up. Maharashtra 0.07% case fatality, and this is data from Puducherry that came out last week. No deaths in the 0 to 5 years, and 99% of deaths took place, of overall deaths took place in those over 19 years of age. So why are children less likely to be affected? There are a few reasons. I will just touch on pathogenesis. The virus binds to the ACE2 receptor on the cellular surface, and then a transmembrane serine protease cleaves the spike protein, allowing the virus to fuse into the cell. This is followed by cytokine release, and in severe cases in the lung, these pictures, this is interstitial edema, fibrinous exudate, microthrombi, and impaired oxygenation. In children, however, there is a decreased epithelial expression of ACE2 and TMPRSS22 compared to adults who have an increased expression. And while adults have increased pro-inflammatory cytokines such as IL-6, children have more of immunomodulatory cytokines. Thereby, they are predisposed to less severe disease. In addition, they have a better CD8 T cell activation, a better humoral antibody response, and we've all heard about how vaccinations help. This is the concept of trained immunity, innate immune memory, natural NK cell response to new infections, which is trained because of frequent vaccination and viral infections. So this is manifested in differences in clinical manifestations. Only about 50% of children present with cough compared to 80% of adults. If you put the symptom complex fever, cough, and breathlessness together, only about 73% of children have that, while that is seen in 93% of adults. Myalgia and headache is very common with adults, and it can be seen in about 25% of older children, that is adolescents. In ordinary SARS-CoV-2 without MIS-C, other symptoms such as nausea, vomiting, abdominal pain, and sore throat and runny nose are less common. So this is what the government of India speaks about as clinical features, saying the majority will be asymptomatic or mild, and the common symptoms are what we just spoke about: fever, cough, myalgia in older children, some sore throat, and some GI manifestation. The labs are also not much different in children with SARS-CoV-2 infection without MIS-C. So you tend to see some, increased lymphocytes and some increased procalcitonin. But if you look at all the other markers that we think of as markers in adults, WBC counts, platelets, PT, D-dimer, AST, all this is increased only in about 15 to 20%. So based on the labs, this was a review trying to see whether you could differentiate between mild and severe, and they said that is not possible. Now, in China, at the initial part of the pandemic, they kept doing CT scans for everybody. For some reason, they found that easier than X-rays. Children, when they have findings, have pretty much the same findings: ground glass opacities, a central consolidation with surrounding attenuation, which is the halo, the reverse halo sign, which is here, a ring of consolidation with attenuation in the center, and when there are septal thickening within the consolidation, that is called the crazy pavement sign. All these, including the ground glass opacities, are found in the peripheral 1/3. But if you were to take CT scans for everybody, you will find that nearly half of them will have normal CT findings. So that is not something that is recommended at all. We are more likely as pediatricians to do X-rays, and this is a consensus statement from last year. They have said this is based on limited pediatric data. It's not been validated. They classified X-ray findings into typical, indeterminate, and atypical. Typical was bilateral, peripheral ground glass opacities or consolidation. Indeterminate was peripheral and central or peribronchial thickening. Atypical was described as lobar consolidation, pleural effusion, or round pneumonia, all of which they said was not typical of SARS-CoV-2 infection. And here again, certain small series have found that X-rays are normal in 33%. So X-rays are not recommended for children with mild symptoms. So I just wanted to share some of the X-rays that you can see with SARS-CoV-2 infection. Perihilar infiltrates, very non-specific, as all of you will agree. Interstitial infiltrates, which can be seen in viral pneumonia. Early ARDS, which is not specific for SARS-CoV-2. And this is thought to be typical bilateral lower lobe consolidation. This is indeterminate when there is peripheral and central ground glass opacities. And this is a round pneumonia, which finally turned out to be a bacterial pneumonia. Making the diagnosis is pretty much the same as adults. The blue line is your NP-PCR, nasopharyngeal swab PCR. It becomes positive between 3 to 5 days and becomes negative in about 50% by 15 days. Although after 10 days, no virus is isolated even if you are PCR positive. This yellow line over here is the fecal PCR, which can persist for a long time, anywhere between 6 to 10 weeks. Luckily, no virus has been isolated from that. So fecal-oral transmission is not thought to be a major driver of infection. Antibodies occur in the second week. This purple dotted line are the IgM antibodies starting from 8 days up to 8 weeks. And the green is the IgG antibodies that also appear in the second week and can persist for anywhere up to 3 to 6 months. So what is evident is that children have a very mild course compared to adults. They tend not to have the progressive hyperinflammatory stage or the late fibrotic stage. And when you look at severity, what is very, very interesting is that although mild, moderate, and severe, mild and moderate may mirror that of adults, severe manifestations are seen in only 2.5% of children compared to 14% of adults. And critical disease is where it is seen in 4% of adults, is seen in only 0.4% of children. So what this actually works out to is that 97% of children do not progress on to the severe and critical phase. And Dr. Winsley will be showing us some of our hospital data as well. Within the severe and critical age groups, there is evidence that the younger ones are more severely affected. So mild disease very classically is upper respiratory infection. There's no way we can differentiate URI due to COVID or anything else. You suspect it if someone else in the family has been proved to have COVID infection. So they can present with any of the symptoms that we spoke about: cough, sore throat, nasal congestion, malaise, some GI manifestations. If they are not tachypneic, what is recommended is home isolation. and antipyretics, paracetamol for fever, ensure nutrition and hydration, monitor, wait for the fever to come down. In moderate disease, which is pneumonia that is defined as fast breathing, most pediatricians have respiratory rate cutoffs for these, 60 for the young infants, more than 50 for those under 1 year, more than 40 for 1 to 5, and more than 30 for more than 5, plus a normal oxygen saturation or a saturation which is more than 94% on 2 liters oxygen. So you will find most of the guidelines talk about 90 to 94. As far as we are concerned, we have in our protocol kept said that if you are it can be less than 94, but if you can maintain it at 94 on oxygen 2 liters, we call this moderate. These children are meant to be admitted into the COVID care center and monitored and provided that they stay on this much of oxygen, no further major intervention is necessary. For severe disease is when there is tachypnea as defined by the criteria above, plus the saturation is less than 90%, plus you are not able to maintain 94% on 2 liters, or if there is any danger sign. So at this point, we ramp up oxygen. We start broad spectrum antibiotics. This is the stage at which dexamethasone is started. This is given for 5 to 10 days. And the reason for giving DEXA is based on the recovery trial, which showed that dexamethasone reduced deaths by 35% in those who are mechanically ventilated and by 20% in those receiving oxygen. Critical disease is basically your worsening oxygenation, ARDS, sepsis, and shock. Dr. Ebor is here. So this is managed by our intensivists. High flow nasal oxygen is started. Some of them can go on to mechanical ventilation, fluid resuscitation for shock, and then vasopressors if needed. DEXA is continued. Anticoagulation is given if there's evidence of thromboembolism. And this is the point at which we start sending tests basically to make sure that this child is not going into a multi-system inflammatory syndrome. So I'm just going to give a brief overview of multi-system inflammatory syndrome. Dr. Satish is dealing with this in detail, and then some atypical manifestations, what is long COVID and what are the indirect effects. So this is the very first case that was documented. This is, I keep saying this, probably the single case report that has been cited the most number of times in literature. A 6-month-old with fever for 2 days, conjunctivitis, rash from day 2, strawberry tongue, and edema and erythema of hands and feet, a complete Kawasaki syndrome. So this baby was PCR positive, treated with IVIG and aspirin, and recovered with a normal echo. This was followed by a 30-fold increase in Kawasaki from Italy and France from April to May. And if you look at percentages, the US CDC reported 10% of all pediatric cases were multi-system inflammatory syndrome. And Dr. Winsley will also be showing you that 4% of our COVID cases from March last year to May this year work out to be multi-system inflammatory syndrome. How does this differ from classic Kawasaki disease? They are seen in older children. Myocarditis and pericarditis are much more common. Platelet counts and lymphocytes are low. Normally, Kawasaki has thrombocytosis. Here they have thrombocytopenia. It occurs 2 to 5 weeks after infection, and is often, because of that late manifestation, is often antibody positive, but can be PCR positive in about 25 to 30% if it occurs early in younger children. Pathogenesis, Dr. Satish will also be talking about. It's thought to be due to immune dysregulation and antibody-dependent enhancement. I'm just showing you this particular picture to show you when MIS-C spikes. So on the left, the black line is pediatric cases in thousands. On the right, the blue line is MIS-C cases in units. So in the US data from March to January, March they had their first peak of pediatric COVID, followed in April by MIS-C. Then the second rise of cases was seen in July, followed by MIS-C in August. So these are things that we should expect anytime we see an increased number of pediatric cases. Just because the cases come down, you can still expect to see MIS-C cases 2 to 5 weeks later. If you were to compare the manifestations between ordinary SARS-CoV-2 and MIS-C has a much more GI manifestations, much less of respiratory manifestations. Among the Kawasaki features, the commonest features are conjunctivitis and rash, followed by lip changes in 30% and edema and adenopathy in only about 15%. A complete Kawasaki is only seen in about 20 to 40% of these children. About nearly half of them can present with shock, and 20% can have acute renal failure. Labs much more different compared to the ordinary SARS-CoV-2. So your CRP and procal are increased in up to 100%. Other inflammatory markers, D-dimer, ferritin, fibrinogen in 60%. Cardiac enzymes, myocardial dysfunction on the echo in about 40%. Coronary artery changes in about 15%. And a minority can have pleural effusion. Definition, the definition we follow is the WHO case definition. Dr. Satish will talk about this again. Just one point to make, that this is a diagnosis of exclusion. So what needs to be excluded are other microbial causes of infection such as sepsis, toxic shock, scrub typhus, dengue, typhoid, all of which we see very commonly in the state. And then another pointer to say that we don't have to, the WHO definition speaks about Kawasaki features, myocarditis, and GI symptoms, but the US definitions also talk about other organ systems. So it's good to be aware: renal, respiratory, neurologic, and dermatologic manifestations. Dr. Satish will be talking about the management of MIS-C, especially from which the protocol that has just come out on 18th June. So I'm not going to talk about that. I just wanted to show you this little graphic. This is 570 cases from MIS-C, and these are 3 small case series from India in the first wave, 19 from Kanchi Kamakoti, 23 from Mumbai, and 17 from our first wave from PICU. What is very striking is that across the board, the major mode of treatment has been IVIG and steroids. Immune modulators such as tocilizumab, which you hear so much about in adults, has been used only in a minority, only in 1 case out of 19 in Chennai, 3 cases out of 23 in Mumbai, and not used in our ICU at all. Long-term follow-up is excellent with IVIG and steroids. Fever subsides within a week. Inflammatory and cardiac markers resolve within 2 weeks. LV function resolves 90% within a month, and in nearly 100% by 3 months, and that is all the same for coronary artery aneurysms. So a bit about atypical manifestations. Because ACE2 receptors are present in almost every organ, these can also be seen without MIS-C. So you can have conjunctivitis alone as a manifestation. I know some of you would have seen that in adults. New onset nephrotic syndrome, rhabdomyolysis, orchidoepididymitis in adolescent children, something like what we used to see in mumps, and a lot of gastrointestinal manifestations such as necrotizing enterocolitis, intussusception, mesenteric adenopathy, pancreatitis, and cholestatic jaundice. Neurological manifestations have been described. This is from a case series from JAMA Neurology of March this year. It is thought to be due to either direct viral entry via the cribriform plate or the olfactory tract, or immune dysregulation. This is from a US COVID registry of nearly 1,700 children. Of that, 36% met criteria for MIS-C, so 2/3 were without MIS-C. Of the 1,700, 22% had neurological involvement. So I'm just going to walk you through this. This is the age groups. The light box here, this is less than 5. The gray is 5 to 12, and the dark one is 13 to 20. If you look at symptomatology, seizures most common in younger children. Loss of sense, sense of taste and smell, more common in those over 13. Headache, altered sensorium seen in older children over the age of 5. 88% of these symptoms were transient. Only a small percentage had life-threatening conditions. This included encephalopathy, stroke, demyelination, Guillain-Barré syndrome, and seizures. Of these 43, 1/3 died, and 2/3 had, of the survivors, about half of them had sequelae at the time of discharge requiring follow-up. Skin manifestations have been described. These are called COVID toes or chilblain lesions. These are erythematous papules or plaques on the toes of adolescents or young adults. Occurs 1 week to 2 months after respiratory symptoms, often PCR and IgG negative, can be IgA positive. The diagnosis was made based on skin biopsy with viral particles seen on electron microscopy and immunohistochemistry positive for spike protein. It is thought to be due to an immune-mediated vasculitis, lasts for 2 to 4 weeks, symptomatic treatment only, resolves without treatment. Other lesions that have been described are purpura, maculopapular or vesiculobullous rash, eczema, urticaria, and erythema multiforme. Just a bit about long COVID. Long COVID has been much in the news for adults. These are people who have persistent symptoms for 2 months or more after COVID-19. This is described in only a few children, totaling about 35. Most of them were adolescents. The longest duration was 6 to 8 months. The commonest symptom is fatigue, muscle and joint pain, something like what you have after chikungunya, and abdominal pain, depression, deranged smell and taste, poor appetite. No one really knows what this is due to. This has not been well, investigated even in adults. Similar symptoms in other family members suggest either a predisposing genetic condition or environmental traits or even stress due to the lockdown. So when we are talking about lockdown, we need to talk about indirect effects. So as we all know, the midday meal scheme has made a huge difference to malnutrition in our state. And globally, the fact that schools are shut down has put nearly 200 million children at risk. As pediatricians, we see children from higher socioeconomic strata as well. And we all know that decreased physical activity in these children leads to obesity. And then having no school leads to increased screen time. This is worrying because increased screen time in the first 2 decades has been associated with increased myopia. This graphic on the right, this is from Austria, shows that screen time pre-lockdown became more than double after lockdown, after the schools were shut. In addition, in adolescents, issues of mental health, such as loneliness, anxiety, addiction, antisocial behavior, and we all know older children locked up at home are prone, in certain situations to domestic violence and sexual abuse. Add to this the effect of educational loss and the effect on future socioeconomic status and earning power. In addition, in Tamil Nadu, it has been documented at least over the past 1 year that child labor has gone up by another 50%. So one of the options is to open the schools, but when you open the schools, this is what happens. This is data from Berlin in Germany. Pre-lockdown, 3 outbreaks per week, 6 cases per outbreak. Then the lockdown, no outbreaks in the school. After reopening, 2 outbreaks per week, 4 cases per outbreak. We may say these are small numbers. Children tend to have mild disease, so why should we be bothered? But when we look at it, these yellow bars, these are actually adults over the age of 21. So which means even though there is mild disease outbreaks in children, predispose their teachers and caretakers to infection, even if the children have mild disease. So how do we open schools safely? The CDC has a toolkit which talks about using masks, social distancing within the classroom, busing children from certain classes in separately, staggered classes, cleaning and disinfection, and modifying ventilation in classrooms. The IAP has a lot of similar guidelines, came out in December 2020. They talk about doing it when the case positivity rate is less than 5%. Cases have been decreasing for 2 weeks, and number of new cases per day should be less than 20 per lakh population. Now, this is a bit far from now it's going to happen. But when I looked at the CDC website, what I was struck by this band-aid over here and this logo that said get a vaccine. So what is the current status of vaccines? Pfizer and Moderna, the mRNA vaccines, have completed their trials for 12 and 17 years old, and it's authorized for use in the US, Europe, Canada, and Singapore. They have started trials in children aged 6 months and over. AstraZeneca has started trials of its vaccine in 6 to 17-year-olds in the UK. It's currently on pause for their regulatory authority to look at safety data from adults. But when this comes out, we will have some idea as to whether we can vaccinate our children with Covishield. Meanwhile, Covaxin trials in children have also started in India in June 2021. And interestingly, in April 2021, UK has advised vaccination of pregnant women with Pfizer and Moderna vaccines based on safety data from nearly 100,000 pregnant women vaccinated. Now, as a pediatrician, why should I be interested in vaccinating pregnant women? And this is the reason. There is actually transfer of maternal antibodies across the cord blood. If you vaccinate pregnant women, I know this has not yet come through, but I think there's a lot of push for this to come through. Interestingly enough, if the vaccine was given more than 6 weeks before the delivery, the rate of antibody transfer was more than 1:1. One maternal is to one, level of antibody in the cord blood. This is higher than what you get with natural infection. And then this study in this we are actually doing now, we are vaccinating lactating mothers. So lactating mothers have been shown to produce both IgG and IgA antibodies. This is data from Pfizer in the US. This is starting at 20 days, went all the way up to 80 days at the time of last follow-up. So that is nearly 3 months of maternal antibodies. This is very similar to what is seen with influenza and pertussis vaccination of mothers. This has been followed by studies from Israel, which I've quoted here, 84 women and 300 women in the US, which I have not quoted here. And both of these studies showed that these had antibodies actually had neutralizing properties. So to end, this is what I wanted to end with. COVID-19 in children is less severe than in adults, even in the second wave. Multisystem inflammatory syndrome is treatable with medications easily available in India. Until we get vaccines for children, vaccinating pregnant women will offer us additional options for protecting infants at risk. We are still learning so much about the pandemic, but the future is not entirely bleak. Thank you. Stay safe, and over to Dr. Satish.
Thank you, Dr. Wilson, for the lucid and very comprehensive talk about COVID-19, covering everything. We'll take the questions at the end of all the 3 talks. And now over to Dr. Satish on multi-system inflammatory. So I request all the IA members to put the questions on the chat. Some questions have come. We'll try to answer that whenever it comes, or we'll take it at the end. Thank you.
Yeah, thank you, Dr. Ebar. Thank you, IMA Ranipet, for inviting us for this webinar. So my talk is to be on multi-system inflammatory syndrome in children. As Wilson said, COVID in children is not very severe. Only very little bit go for the very severe manifestation, so that most of the time they can manage at home. But this is a new thing, new wrinkle in the COVID infection. So in the next 20 minutes, what I am going to talk to you is about this nomenclature, what is called PIMS-TS, what is called MISC, and when to suspect this condition when you see a child in your OPD. And if you suspect, what you should do, and what are treatment guidelines available. And the government of India has issued a new guidelines for how to treat this condition, and what is our CMC protocol for treating this condition. So as you all know that during the last year when the adult COVID came, there is an increased incidence of Kawasaki disease in Italy. So they thought, why this Kawasaki, this 30 times increase in the incidence of Kawasaki disease. So that's the first time they thought whether something to do with this COVID infection, but it happened after the adult COVID peaks. So the first report came very early from the French group with 16 children. They called us Kawa COVID because they had manifestation of Kawasaki disease. Then from the UK, 58 children, they called us pediatric inflammatory multisystem syndrome temporally associated with SARS-CoV-2. Then from the US, it came the next paper, the first paper, the 186 children with MISC. So as these are the 2 big series of PIMS-TS from India, which is published from during the first wave. This is one from Mumbai who had 23 patients, one from Chennai who has got 19 patients. VS is under publication. So when you talk about this case definition for diagnosis, there is a UK definition, there is US definition, there is a CDC definition and WHO. Almost everything is similar apart from mild changes. But if you look into WHO classification, this is very simple and easy to follow. Very simply, they say any child who has got fever more than 3 days during this pandemic period, if they come with two of the following, either they can have non-prolonged conjunctivitis or they can have mucocutaneous lesions, especially in the oral hand or feet. They can present the shock, they can present the myocardial dysfunction, evidence of coagulopathy, and they can have GI symptoms, abdominal pain, diarrhea, and vomiting. They'll have elevated ES and CRP. And remember, no other obvious microbiological cause should be there. And evidence of recent COVID infection, either in the form of contact or RT-PCR or serology can be positive. See, the problem with this diagnosis is it will sometimes lead to overdiagnosis, especially in our condition. So we see a lot of enteric fever, shigellosis, even appendicitis. So if you look into this criteria, you can see that so the enteric fever can have shock, shigellosis can have shock, evidence of coagulopathy will be definitely PT. The sick children, they'll be elevated, they can have diarrhea. So if you look into this thing, remember that the blood culture most of the times may not come positive also. We treat always like sepsis with the DIC. And during this time of pandemic, every child is exposed to COVID, somebody in the family. Even you take the routine, dengue, leptospirosis, or rickettsial infection, which we see again in our practice, day-to-day practice, they can present again with shock, they can present with coagulopathy, they can present with GI symptoms. In dengue, we don't see elevated ESR or CRP, but other things like rickettsial, leptospira can be increased. Dengue is easy to diagnose because we have the NS1 antigen, which can be positive. Again, COVID contact can be there for a lot of children. So we have to be very careful. So what they did was, so based on these confusions and overdiagnosis of MIS-C and treating the normal or common infections as MIS-C, the government of India has published a new guidelines yesterday. They just changed the guidelines to our local place. If you look into this, so the remaining, they kept it the same like WHO. Clearly, they're given here, alternative diagnosis must be excluded before making a diagnosis of MIS-C. So what is the alternate diagnosis? What we see, malaria, dengue, scrub typhus, enteric fever, toxic shock syndrome, and bacterial sepsis. So this is going to be very, very important, especially when we practice in Tamil Nadu, because we see a lot of tropical infections more before you jump and give high-dose steroids to these children at the time of presentation. So epidemiology, so it's 2 per 1 lakh children. So it is not very common disease. 80% of them require ICU care and the mortality is around 2%. So this is one of the recent review, looked at to systematic review, looked at to all the children admitted with the MIS-C all over the world. This is published in European Journal of Pediatrics in February. So what they found out is it is usually happens in the older children, 8 years older children and obese children. Fever will be there in almost everybody. Lot of times the gastrointestinal system symptoms are the very common, diarrhea, vomiting. 85% of the children have diarrhea and vomiting, followed by cardiovascular symptoms like tachycardia, myocarditis, shock. Then they can have almost 60% of them can have Kawasaki-like illness. So gastrointestinal involvement, CVS involvement, and Kawasaki involvement are very, very common. And again, 80%, 85% of them present with very sick, needing ICU care. Remaining 10 to 15% can be very mild, that can be managed in the ward. And if you look into this, PCR can be positive still in 40% of the people. We know that RT-PCR can be positive up to 2 to 3 months after the acute COVID infection. And IgG is positive only in 70%. Treatment, we'll talk about that in detail. And as I told you, the mortality is less than 2%. So MIS-C is not a single disease. It's not, so it can present with 3 main phenotypes. They can present with acute inflammatory state, presents only with fever and raised inflammatory markers. They don't have shock. Sometimes they present like KD-like illness, only like Kawasaki-like illness. They can present without shock or any multi-system involvement. The third group is called severe MIS-C, where it has organ involvement. So as I told, MIS-C, this is another one paper from British Pediatric Surveillance Unit. What they found out, they collected all the patients with MIS-C and they found out Few of them are associated with Kawasaki-like presentation. Some of them have toxic shock syndrome also, and some of them had Kawasaki disease-like presentation with shock. So this is not a single disease. We have to see this child as a syndrome. So this is the difference between the classical pre-pandemic KD and MIS-C. So with the MIS-C, as I already told, it is more than older children, more than 5 years. They have a lot of gastrointestinal dysfunction symptoms, cardiac dysfunction, myocarditis. Normal KD usually have coronary artery abnormalities, but here they have myocardial dysfunction, shock, coagulopathy. They can also have MAS. And in the investigations, if you look, they have very high CRP, usually in 3-digit CRP. Ferritin can be high, D-dimers are high. If the cardiac involvement is there, cardiac biomarkers like NT-proBNP and troponin will be very high. So this is the difference between the pre-pandemic KD and the KD associated with MIS-C. So this is a typical what Wilson already showed this picture. So usually when the adult peak comes down, so you can see in this yellow is the adult peak cases, background COVID cases in the adults. You see that MIS-C comes up when the adult peaks comes down. So this is what we have to see now, what we are seeing in our ICU. Every day 2 patients is coming with MIS-C, because now you see the adult COVID numbers are coming down. That's what we are seeing. And the median age is about 25 days. So 4 to 6 weeks is the usual time when the MIS-C appears. So when you want to talk about the immunopathogenesis, so to make it very simple, MIS-C will not come to all the children who had COVID infection or contact with COVID. It presents with only with few people who has got immune dysregulation and some genetically predisposed children. So they have problem with the innate immunity and with the adaptive immunity. Both the immune systems are very active, leading to a lot of autoantibodies, leading to tissue damage. So this is one of the diagram from one of our papers on immunopathogenesis of SARS-CoV-2. So genetically susceptible individuals, very, very important. On them, if you have the SARS-CoV-2 infection, based on the antibody titer and the exposure, your antibodies are stimulated and leading to multi-system inflammatory syndrome, leading to fever, myocardial dysfunction, GI symptoms, neurological symptoms, and fever. So when to suspect this? When you're in your OPD, sitting in the OPD, any child who comes with fever more than 3 days without any focus of infection, we should suspect whether it could be MIS-C. Or when they present with Kawasaki-like illness, GI symptoms, these two are the very common things, or with shock. So these 3 symptoms are there. Again, we should suspect MIS-C in children in the OPD. So I'm going to show you some pictures of the rash. So this is one of our patients who present like a Kawasaki illness. You can see this red eyes. This is one of the patient in the ward now from ARCAD. She's a girl with SLE actually. She came with 10 days of fever. And the day we admitted, we thought whether it could be disease flare or infection. But the next day she developed this typical red eyes. These are the patients with the rash in the body. Again, Kawasaki-like presentation, edema. This is one big boy who has got the rash like this and the pedal edema in a child with Kawasaki-like presentation. So these are the common rashes which see in the MIS-C. So how do you investigate? When you suspect MIS-C, the child is well, when the child is in the OPD, when they come with fever for more than 3 days, or mild diarrhea, no shock, nothing is there. So what you do? So as you routinely see any child with a fever more than 3 days, you do CBC, ESR, CRP, electrolytes, creat, LFT, blood culture, and RT-PCR and serology. Both has to be done when you suspect in the OPD. So if anything like that, CRP, especially in all our children, we see CRP in 3 digits, especially more than 100, ESR, if they have lymphocyte count less than 1,000, platelets less than 1.5 lakhs, hyponatremia, neutrophilia, and hypoalbuminemia, all suggest this child has got MIS-C. Remember that you have to rule out the common infections also. Dengue, Vidal, wheal flix, dengue also has to be ruled out. When somebody comes with severe manifestation, especially with shock, diarrhea, shock, previously what we do, AG, 10% dehydration, shock, we give fluid bolus, we start antibiotics, and we admit the children in the ward. But during this pandemic, if somebody comes with diarrhea and shock, we should evaluate for severe form of MIS-C because child has got shock. We have to evaluate for cardiac by doing echo, by doing cardiac enzymes, ECG, then other markers, inflammatory markers like procal, D-dimer. D-dimer comes here in the severe manifestation who are going to get admitted. No point in doing D-dimer for a child in the OPD with 3 days of fever. It is not going to help you. It is not going to predict whether this child will become sick later. Again, SARS-2 serology has to be done. So when you see, how will you manage stepwise? So you suspect in the OPD when somebody comes with fever more than 3 days, or clinical features I told you, KD-like picture, GI symptoms, or the presence with shock. If the child is life-threatening shock manifestations present, then you do the first tier 1 and tier 2 investigations. Also, you send for common intraopical infection workup, Vidal, Wheel Felix. Please do all those things. If it fulfills the diagnostic criteria for MIS, then you treat like that. If suppose a child is very well, you look for the alternative diagnosis and monitor the features for MIS. If the child develops features for MIS, then you have to do tier 2 investigations. Okay, so when it fulfills the diagnostic criteria, you always treat those children for life-threatening involvement, or you just wait for the child to develop. Don't jump and give on the day 1, okay, Miss C, I will give IVIG on day 1 without the child is sick. Okay, so that's what happened to adult COVID. Anybody comes with fever, you give remdesivir. And this is the way you have to evaluate a child for Miss C. Okay, again, yeah. So treatment guidelines, when you're talking about the treatment guidelines, various treatment guidelines are available when you open the thing. So these are the initial guidelines from UK and US. Then finally, the US American College of Rheumatology in April 2021 gave a treatment guidelines for MISC, which was quoted in all the other, based on this only all the other guidelines were made. So what they say is, because it's a post-inflammatory syndrome which happens 4 to 6 weeks after acute COVID, so remdesivir has got no role in the management of MISC. An antibiotic as per your local protocols, whatever you want to give in your hospital, you please give. Then the immunomodulation part, what they divide them into MISC into 2 categories, 2 phenotypes, with shock, without shock. If they present with shock, they want to give IVIG and methylprednisolone. If they are refractory, you give high-dose methylprednisolone and anakinra. If they don't come with shock, you give only IVIG. And if they have refractory disease, you give methylprednisolone. If there is no improvement, you give anakinra. Antiplatelet, low-dose aspirin, when they present, especially with Kawasaki-like phenotype, they have thrombocytosis, or if the coronary artery Z-score is 2.5 to 10. And you continue aspirin till the coronary artery aneurysm resolves. Enoxaparin, anticoagulation, they are very specific. You give only if the coronary artery Z-score is more than 10, that's a large aneurysm. If they have a documented thrombosis or severe LV dysfunction, ejection fraction less than 35%, then only we should use enoxaparin. So obviously enoxaparin children will be in the ICU. So children who are admitted sick in the ICU needs enoxaparin, not the children who are admitted in the ward. Hyperinflammation, this is like a MAS-like picture. When they present with shock, multi-organ dysfunction, the bicytopenia, very high ferritin, then you think of giving high-dose methylprednisolone and anakinra. Anakinra is IL-1 blocker, which is not available in India. Remember, this is the protocol from American College of Rheumatology. If anakinra is not available, we can use tocilizumab, which is a IL-6. And IAP has come with a new protocol. Okay, so IAP was what? The IAP was little very, looking into all the literatures available. They said if they come with shock phenotype, you give high dose steroids. That is 10 to 30 mg per kg and IVIG, both you should give. And then you reduce it when the child is getting better. Consult expert for biologics. If it is a KD phenotype, they want to give IVIG and low dose methylprednisolone 2 mg per kg. If they don't get better, then you go to 10 mg per kg. Mild MIS-C, that means the patient has got only fever and raised ESR CRP. You have ruled out all the alternative diagnosis. That means your dengue, Vidal, Wheel Felix, everything is negative. You can consider giving 1 to 2 milligram of steroids, prednisolone, for 3 to 5 days. So this is for the mild MIS-C without any shock. And again, June 9th, Lancet COVID-19 Commission Indian Task Force paper from all the pediatricians. They had Dr. SPS, Dr. Vinci Rose from our institute is there. They had a recommendation for treatment of MIS-C. They also divided them into mild MIS-C and moderate, severe MIS-C. Mild MIS-C, as I said, This is like a febrile inflammatory state. They want to give only low dose steroids for 3 to 5 days. If they have severe MISC, when they have the cardiac dysfunction, multi-organ dysfunction, very high shock, they recommended to give high dose IVIG 2 grams per kg and low dose steroids. And if they don't get better, they want to go to high dose steroids. High dose means 10 to 30 milligram per kg, maximum of 1 gram of methylprednisolone. And you taper steroids 2 to 3 weeks while then monitor the inflammatory markers. Okay, so remember that issues with all the guidelines keep on changing. Guidelines are formed based on that particular day, what is available data, and guidelines change from area to area. We cannot follow the American guidelines straight away. Anakinra is a drug they recommend, which is not even available in our India and not practical in the resource limited settings, especially IVIG giving for every child on severe COVID. MSC to give IVIG is a very difficult one. So go by clinical judgment. Close monitoring is very, very crucial. Step up or step down depending on the clinical scenario. And you should also keep updating your knowledge with the evolving evidence. So yesterday, 18th June 2021, Government of India has given a management protocol for all the types of COVID in children. I think we should go through these guidelines. Very simple, very practical, very good for our own condition. So what they had did is they made into 3 different phenotypes: MIS-C with shock, Kawasaki phenotype, MIS-C without shock. So in MIS-C with shock, that means severe children, they want to give IVIG and you give 2 milligram per kg of steroids. Don't give pulse steroids without ruling out infection. You wait for 48 to 72 hours. If that time you will get all the infections ruled out, then you go to high 10 mg per kg. If they have KD phenotype, you give only IVIG, again 1 to 2 milligram per kg steroids. Wait for the symptoms to settle. There is no role of high dose methylprednisolone in KD phenotype. Consult specialist for biologics. MIS-C without shock, that is where febrile inflammatory state in the ward patients. You give only methylprednisolone 1 to 2 mg per kg. Always remember, use biological only after expert consultation and at a tertiary care only. So this is what happened when the second wave came. There is no clear-cut guidelines for adults. This is what a lot of adult physicians told me. We don't have a clear-cut guide. I asked them, why are you giving tocilizumab for everybody? Because there is no clear-cut guidelines. But now for children, Government of India has given a very clear-cut use biologicals only after expert consultation and at a tertiary care level. So we have made a protocol apparently during the starting of the second wave itself. After discussing with our ID team and our ICU team, we are little more than the Government of India protocol which released yesterday. We had divided into basically 4 major phenotypes. The first phenotype is the febrile inflammatory state, which we already talked about, which is MIS-C mild. You rule out all the other infections, then you give very low dose steroids 2 mg per kg for 3 to 5 days. Then MIS-C with shock phenotype, mild shock, moderate shock, and severe shock. Mild shock, you give only methylprednisolone, don't give IVIG at all. And if they come with severe shock, you give IVIG plus low dose steroids. If they're not settling, you go to high dose steroids. And life-threatening disease, if they have 2 organ damage, then you give IVIG and you give methylprednisolone 2 mg per kg. In KD phenotype, you give IVIG is the first line of choice. You give IVIG plus aspirin, and the last group is your HLH type, which is very severe type. There we have to give high dose methylprednisolone. So this is the way we treat MIS-C in our ICU. So what are the key messages? So remember that MIS-C is not a single disease. We have 3 different phenotypes: febrile inflammatory phase, Kawasaki disease-like picture, and shock-like state. Both are dangerous. Either overdiagnose a dengue and you give IVIG and steroids, or rickettsial infection, you give IVIG. That is also dangerous. Sometimes you delay and after the child goes into shock, myocardium is much involved. Both has to be avoided. And remember that in India, still we are seeing a lot of tropical infections. That has to be always keep in the mind. Treatment has to be tailored according to the phenotype, and it's usually a team work with the pediatrician, intensivist, cardiologist, ID person, and rheumatologist. And I'll stop it here. So this is the guidelines which came out yesterday. Thank you for the opportunity. Thank you for the patient hearing. Thank you. We'll take questions.
Thank you. Thanks, Dr. Satish, for the clear message and the lecture. And so I know that a lot of questions will be there. Already Dr. Wilson is answering some. We'll take the questions at the end. Now I request Dr. Winsley Rose to share his screen and to talk about prevention strategies of COVID-19 in children. Over to Dr. Rose.
So good evening. Thank you.
No, you go ahead. Go ahead. I wanted to all the other audience
to be muted. Yeah. Okay. So can you see my slides and can you hear me? Okay.
Yes, we can see and hear, please.
Okay, thank you. Thank IMA Ranipet for this opportunity to talk a little bit about COVID. I mean, you heard the two good sessions on the clinical features and MISC. Finally, I'm going to just talk a little bit about prevention of COVID-19 in children. And so what I'm going to cover in this next 10-15 minutes is to figure out whether we really need to prevent COVID-19 in children. And if we need to, then how do we do it? So I thought I'll just put up some numbers. First is this slide, which actually shows you the COVID-19 deaths by a 5-year age group. So if you look at it, I mean, you can also look at the trajectory of these deaths. I mean, if you divide all the deaths in 5-year age groups, you can make out that the highest number of deaths are in the oldest age groups. I mean, once you hit 50, 55, 60, that's when the highest number of deaths are. And you look at the age group between 0 and 19, there is very, very little number of deaths. And it actually, Dr. Wilson also mentioned that it's only about 0.3% of all the deaths that have happened. Now, compare that with the COVID-19 cases which have been confirmed. Now, this graph, I mean, this bar diagram actually shows you the distribution of the cases, again, in this 5-year age brackets. So you can see that the bulk of the people who are infected are actually in the middle age group, somewhere between 20 and 50. That's the age group where bulk of the people are infected. But if you look at where the deaths are, that is in the oldest age group. Now, I've just tried to overlay those two graphs. So the darker blue is the deaths and the lighter blue, it's the distribution of the number of cases. So even though the distribution of cases is actually in the very young age group, it's as much as the very old age group, but the number of deaths are much, much less compared to the older age groups. So this slide actually shows you, the population distribution and the number of COVID confirmed cases by age group. So it's not like, in the sort of background, you can see one light blue bar diagram that actually shows you the age specific population. So if you look at the population for that particular age group, like for example, 0 to 4 years is actually about 4.5%. But if you actually look at the number of cases, it's actually much less compared to the other age groups. So it's not like not only are children, less children die because of COVID, but also less number of children also get infected because of COVID, even though, which is disproportionate to their population size. This is a graph from the United States, which actually looks at the cumulative the number of cases of COVID, which has been a weekly distribution of the number of cases. So when we started off last year in April, about 2.6% of them were children, whereas at the end now in the past couple of weeks, it's about 17.2% of the child cases. And they've had like, almost 3 waves, which has gone on over the past 1 year. We do not have information like this from India. But if you look at these American literature, this is the reports as of last week. About 14.1% of children actually have had COVID. Out of the total COVID, 14.1% was in children. I want you to contrast that with the number of hospitalizations. Even though 14% had disease, the number of hospitalizations is actually only between 1.4 and 3.2%. So about 2% hospitalizations. And you look at the number of deaths after that, I mean, that is anywhere between 0 and 0.03%. So not only do children, disproportionately represent a smaller number of the cases of COVID, a lesser number actually require admission, and even a very small number actually die because of COVID. This is our own data. Dr. Ebor also showed this. If you look at, this is the number of cases over the last year who've been diagnosed with COVID at CMC. On the left corner, I've also showed you the Indian total number of COVID patients in India. And you can see the wave, the first wave, which was a gentle wave, and the second wave, which is like a huge peak. Our data also mirrors that same thing, where we've over the past 2-3 months, we've had a huge surge in the number of cases who've been admitted with COVID. Now, out of the 23,000 odd positive people who were, positive tests which are there in CMC, about 988 were among children. This is up to May 31st of this year. So our positivity rate is actually much less, which is about 4.3%. This could also be because a lot of our asymptomatic children, we don't necessarily test. And it's only often we test only when they require hospitalization. So I've sort of looked at if there are any differences in our children between wave 1 and wave 2. What would you call a wave? That's a bit nebulous. But how I've classified it here is to actually consider it as wave 1 till February 2021, and then whatever happened after that as wave 2. So if you actually look at the number of the proportion of asymptomatic or mild cases, about 90% of them actually had only asymptomatic or mild cases. Moderate was another small percentage, but out of the severe, critical, and MISC, mind you, Satish and Ebor told you that our MISCs, we've had many more children than this with MISC. But what I've shown here is only those who are RT-PCR positive. So MISC being an inflammatory state post-COVID, a lot of them will have their RT-PCR being negative and only their antibody will be positive. So these are all children. This is all children who had their MISCs with the RT-PCR also being positive. So if you look at severe, critical, and MISCs, it forms about 8%. And there is no difference between these numbers, whether it is wave 1 or wave 2. And even if we go with further waves, I don't think there will be much of a difference with the profile of patients that we see with regards to COVID. I also looked at the number of children that we've had who died being COVID positive. So we've had about 10 deaths over the past year or so. Now, if you look at the deaths, out of these 10 deaths, I've put up the comorbidities. Apart from one child, that serial number 2, apart from that one child who we don't know whether there was an underlying comorbidity or not, because this was a 37-day-old who came with diarrhea and shock, and then after that developed HLH and then died after a few weeks. So that child, we don't know whether the HLH was primary or was it secondary to COVID itself. But apart from that, every other child who died actually had very severe comorbidities. I mean, it's leukemia, it's severe primary immunodeficiency. Well, there was one child who was post-BMT with Wilson's disease, severe cardiac defects. So underlying very severe comorbidities, and they died being COVID positive. Also, another thing which I want to highlight is that 4 of the 10 actually were less than 1 year of age, and another 2 were at 1 year of age. So what I'm trying to say is they are likely to be, the younger children with comorbidities are likely to die more than older children. This has also been shown in this data, which is actually from China, where they've shown that severe and critical disease with COVID was more common among children less than 1 year of age compared to the other age groups. I want to just contrast that with MISC. You heard a lot about MISC. Now, look at the age distribution of MISC. It's the age distribution of MISC. The bulk of it actually happens after 5 years of age. So if you just say, less than 5 years, if children have severe comorbidities, they are likely to become sick with COVID. But after 5 years is where MISC happens. And Dr. Wilson also showed you graphs where MISC actually lags peaks of COVID-19 by about 1 or 2 weeks. And this is data from the US, which actually shows that very clearly. Also, MISC is more common among male children, about 60-40 divide. So, I mean, in summary, what it seems like is children have lesser disease. They also have less severe disease and lower mortality. Of the pediatric age group, if a particular group were to become sicker with comorbidities, it is often the infants. One needs to be concerned about MISC in older children, which is a rare condition. Dr. Satish mentioned it's only a 2 per 1 lakh population, but it is a serious condition. You need to recognize it and act proactively about it. And there is no difference between wave 1 and wave 2. So even if there is another wave, we don't think there will be a difference in the severity of illness. So with all that, do we really need to prevent COVID-19 in children? So I would think, see, COVID-19, it's affected large proportions of the population. So even if the mortality rate is very low or children becoming sick is very low, but just because of sheer numbers, you will have a lot of children coming in sick with COVID-19. So I think there is some benefit in actually preventing them in children. And children can become sick. Without vaccines, when the rest of the population is vaccinated, you'll have the child population which won't be vaccinated and becomes a susceptible pool. And once children become the susceptible pool, it also becomes an important transmission pool, especially to unvaccinated adults in the household. Also, we don't know what will happen to transmission among children once school starts. Because right now, all the transmission to children has actually happened from adults. Everybody is sitting around at homes and all the children also got infected from their parents. But we don't know what will happen once school starts, what the rate of transmission will be among children. There are some studies to show that transmission among children is not as bad as influenza, where the prime driver of transmission is actually among children. Whereas in COVID-19, it seems the other way around, where the prime driver of transmission is actually adults, and it's from the adults that the children get this disease. Also, if a child becomes infected with COVID, you'll have issues with quarantine, isolation. I mean, all these things are not easy when it comes to children. So I think for all those reasons, it is probably useful to prevent it in the first place from happening to children. So how do we protect children? I think it's the same basic tenets that we follow for protection, even for adults, which is basically masking, distancing, washing hands, and use of vaccines. I like this WHO chart, which actually tells you how you can make yourself safe. So I think these 3 things we'll have to keep in mind. I mean, any interaction that we have with another person, we'll have to see whether that interaction is a safe interaction or not. So So the three things to consider are: one, whether the location of the interaction. Like if you are sitting inside a closed room, like for example, a classroom, then your risk of transmission is higher compared to an open space. Like, if you're playing outside in the park or you're having an outdoor game, your risk of infection is much lower. Similarly, the closer you are to another person, the risk is higher. So if you're less than 1 to 2 meters from another person, your risk is higher. So then you need to see whether you need to actually protect yourself by using a mask or not. And also the time spent in close quarters. So the shorter time you spend with someone in close quarters, the lesser chance of infection. So I think every of these interactions, if you can actually think about whether the one is the location, the distance between yourself and the other person, and the duration of this contact, then we can actually protect ourselves. And if you teach them to the children, and we can protect the children as well. So mask, there are many varying guidelines which actually have basically tried to balance the idea of safety of using mask in a small child versus the protection that is required. Not just the safety, but also the ill effects of mask use, especially with regards to social interaction. So the WHO recommends actually mask use above 5 years of age, but CDC and the Indian Academy of Pediatrics actually recommend mask use above 2 years of age. And anyway, about 12 years of age, you should treat children like adults, where they use mask at all scenarios where an adult would use a mask. What mask could be used? So WHO recommends that if it's a healthy person, you should use a fabric mask. And if it's an unhealthy person, like, if you've got somebody with underlying health conditions, then they should use a medical mask or a surgical mask. I mean, equated, they both are the same, medical mask or surgical mask. And CDC, on the other hand, recommends either cloth masks, and they also say that if you use a double mask, that even better. IAP recommends a simple surgical mask. And when should you use it? So again, there are some differences of opinion. WHO says if you come into contact with, if the contact with another person is less than 1 meter, then you should use it. CDC recommends that in public, you should always use it. And in the homes, if someone is infected, then you should use it. So, but I think the important thing is to recognize what are those risky aspects that you need to consider. So at least 1 meter, but I would say, safest is 2 meters. If you're in contact with another person with a distance of less than 2 meters, then you should consider using a mask. And what mask? It could be best would be a surgical mask or a medical mask. But if you don't have that, then probably a cloth mask will also help. Cloth mask, which actually it will help you from actually transmitting it to another person, but does not really help you from preventing yourself from getting it from another person. Whereas a medical mask or a surgical mask will help you from prevent you from getting it from another person as well. Then washing hands. I think it's important that we teach our children how to wash hands, and not just for COVID, but even for other reasons. I think it's important that adults show the way in when all children should wash hands. One key thing to remember with the COVID pandemic is to also wash hands before and after wearing a mask. Now, what should we wash our hands with? Hand washing with soap in this, where you wet, lather, scrub, rinse, and dry. And how long should you hand wash? At least 40 seconds. The next option, the other option is to use alcohol hand sanitizer, where you should use at least 60% alcohol. Only then is it effective, and the duration of that will be about 20 seconds. And very importantly, I still think it will be the adults who should show the way with regards to hand washing or using of alcohol hand sanitizers. When all should they use? After using the bathroom, before eating, after touching pets, after playing outside, after coughing, sneezing, or blowing their nose. So hand washing, masking, and hand washing, masking, distancing, and finally vaccines. Dr. Walson also already mentioned that there is right now in India there is no vaccine which is approved for use in children, and in the United States, all children above 12 years have been offered vaccines. The Pfizer vaccine, which is given 2 doses 3 weeks apart, it's got extremely good efficacy. In fact, they claim 100% efficacy in 12 to 15-year-olds. That is even better than children who are older 16 years of age. The over 16, the efficacy is slightly lower, but in 12 to 15-year-olds, the efficacy is 100%. And they have very good antibody responses as well. And among 6 months to 11-year-olds, there are still studies underway. The Covaxin trial has started for 12 to 18-year-olds earlier this month. The viral vectored vaccines, that's adenoviral vectored vaccines, AstraZeneca, as well as Johnson & Johnson vaccines, they started off their trials in February, but their trials were paused because of the increased risk of clots in younger adults. So we'll have to wait to see what happens to that. I mean, when I say increased risk of clots, it's not a big increase. It's actually 30 in a 15.8 million doses. So you can sort of imagine it's actually 1 in less than 500,000 doses. That's like 1 in less than 5 lakh doses. So that's the risk. But even then, because it happened, they've actually paused these trials among smaller children. Now, what is it with breastfeeding and COVID? One thing is for sure, breast milk transmission has not been documented. So you can't transmit through breast milk, but just the proximity of the mother being, the proximity with the child during the process of breastfeeding, that is a risk where children can get COVID from mothers. But should they stop breastfeeding? Definitely not. Mothers still should continue to breastfeed unless they are too sick to breastfeed. And kangaroo mother care is also advised because the benefits actually definitely outweigh the risks of not breastfeeding. So how should a mother breastfeed if COVID positive or if she's suspected to be COVID positive? She should wash her hands frequently with soap and water or use alcohol-based hand rub, especially before touching the baby. Wear a surgical mask or a medical mask during any contact with the baby, including while feeding. She should cough or sneeze into a tissue and then dispose it off immediately and then wash hands again. And routinely clean and disinfect surfaces that the mother has touched. Now, what about if a family member has COVID-19? What do you do with the children? So best thing is to isolate the family member from the rest of the family and maintain at least a 2-meter distance from that family member and wear mask if closer contact is anticipated. Like I told you, I mean, I think we'll have to be prudent in what we do. Not only do we put them in a, more than 6 feet gap, they should be in a separate room with good ventilation, which again actually helps in decreasing transmission. Now, what if a child has COVID-19? The child should wear a medical mask as long as they can tolerate it. Child should be isolated and medical advice sought as soon as they start to feel unwell, even if their symptoms are mild. And family members and caregivers who come within 1 meter of the sick child at home should also wear a mask when caring for this child. So in summary, children are not severely affected with COVID-19, but it's useful to follow the basic tenets of COVID-19 prevention, especially masking, hand washing, maintaining distance, and vaccination whenever vaccines become available. And children are much more vulnerable to the ill effects of social distancing and masking. So we have to be careful about that as well. And we have to take into account the many challenges faced by children, especially with regards to social isolation, lack of proper education, and also the family's economic burden. I mean, Dr. Walson mentioned in his talk about the issues with regards to these issues as well. So those are another dimension which we need to take into account. Yeah, so with that, I'll stop and hand over to Dr. Ebor for further discussion and questions. Thank you for your patient listening.
Thank you, Winsley. Thanks for taking us through the numbers and our experience and prevention strategies. So, we have any questions? We already, Dr. Walson and Satish has answered many questions. And there is one last question. You can probably unmute and ask as well. Otherwise, we can discuss in the chat. And there was one question, when can we do surgery on a child who's COVID positive with respect to preventing transmission to elsewhere?
Current guidelines was 18 days. That is 10 days of quarantine and 7 days later. So 17 days, 18 days post positive test surgery is allowed in CMC.
Yeah, that is for an elective surgery,
Elective
right? And
surgery.
for an emergency, probably in a COVID theater, they may take.
Yeah, exactly. Or you can actually probably
All
read
right,
out some
and,
of the questions. I was just saying,
yeah,
you could probably read out some of the questions and the
right,
answers.
correct. So that's right. There was a question on role of antibiotics in MESC. Well, you want to answer? You have already answered that.
Yeah, so I think what I mentioned was, so the question was, what is the role of antibiotics in approved MIS-C? And I think Satish has brought that thing out that, when they present initially, we often find it difficult to differentiate between a sepsis, septic shock and a MIS-C because the presentation is very similar. So that is the reason for starting antibiotics. We normally wait for the blood culture. If the blood culture is negative, we can step down. But it also, the problem is by now that time, if it's MIS-C, the child is in ICU on steroids. So at that point, it is just prophylactic and is given only till the child is discharged from ICU.
So as
So
I told
antibiotic
you,
shock, it's septic shock. It's very, very important. Even in the first hour, we need to. So we are the close mimic is septicemia in shock. So I think we have to have, especially when the patient coming to ICU, there is broad spectrum antibiotics. As otherwise, steroids is also on. So yes, Satish, you want to say something?
Yeah. So once a child comes out of ICU to the ward, usually we stop. By the time culture will be negative, or sometimes we downgrade to routine cefotaxime. In ICU, when the child is in shock, they may give meropenem and other antibiotics according to their ICU protocol. Once the child comes out, we downgrade them to usually to cefotaxime. And the child go home, we don't usually send on antibiotics.
And there was another question I must see about the risk factors. Already Satish answered that.
Yeah.
Yes, we do see children, they are big and obese or overweight teens, they are quite severe. Most of them have gone into severe shock. In the previous wave, 2 of them have gone for ECMO as well as severe cardiac dysfunction rather than little younger children. And mostly even the incidence in the literature is between 8 to 15 years. Is it, Satish?
Yeah.
Right? More common?
Yeah. The other thing is we always know that Kawasaki disease also come for a well-grown child, like chubby children. I know their immune system is overactive or they respond to any infection too much compared to the child who is like a normal weight or low weight. Most of our Kawasaki disease children are obese actually.
And there was about a HLH presentation. Satish already responded. You want to answer that?
Yeah. So the HLH is one of the presentation of MISC. So they have bicytopenia, especially like typical like a HLH, bicytopenia, liver cell dysfunction, ferritin more than 10,000. Be extremely very high, hypotension, shock, multi-organ dysfunction. Those patients, we give high dose steroids on day 1 as we said in our protocol. And if they don't respond, we go for tocilizumab. And IVIG usually is not very helpful in that presentation.
Yeah, but see the HLH, we have put it as one of the phenotype, but usually they don't come at, it is very difficult to identify at the time of admission. They will be in severe shock, that's all. So we may not do even the ferritin at the first. When they are not responding after 36 to 48 hours, when what we call the refractory disease, that time only all the cytokine panels we send. And if they are not responding, as Satish mentioned, so we go for the pulse steroids. And there was a question about loss of taste and smell, more seen in older children, right? And not younger children. Balsan, you have answered that.
Yeah, so what I said was one is perceptions. Younger children don't complain of that much of loss of sense and smell. But no one knows whether it's also because younger children have less of ACE2 receptors and whether it's actually, they are actually less effective.
Yeah. And about nephrotic syndrome in COVID, is the management different from the usual nephrotic?
No. So it's very good response with the usual steroids.
Sure. And about the diabetes and hypertension post-COVID in children.
Yeah. So no reports of new onset diabetes and hypertension in children post-COVID.
And there was about aspirin and steroids, whether it can aggravate GI symptoms.
You want to answer that, Ebo?
Yeah. So
that,
aspirin, remember that in MIS-C, there is no role for high dose aspirin, especially when you give for 80 to 100 milligram and all. It's not advised, even though it's a Kawasaki phenotype, because normal Kawasaki will have high platelets. As I said, this MIS-C Kawasaki type phenotype will have low normal platelets. So we don't give high dose aspirin. Aspirin is given as an anti-thrombotic effect when they go home, 3 to 5 milligram, especially if they have coronary artery involvement or if they have a KD phenotype alone, or myocarditis with severe dysfunction is there. Otherwise, routinely high dose. So we don't use aspirin when the child is sick in the ICU.
Yes. And another question about antibodies to vaccine in children. Whether will it cause MIS-C like picture?
So I answered that, and the reason, it's a very good question, because we are saying antibodies and antibody dependent enhancement. So most of the vaccine trials have been aware of this. Winsley will remember dengue vaccine trials. Actually there were antibody dependent enhancement is one of the causes of, severe secondary dengue. So in fact, for the dengue vaccine trials, people actually noticed worse outcomes if you had dengue after a vaccine. So people have actually looked for it here. Antibody dependent enhancement has not been documented in any vaccine trial so far. So as of now, and most likely, antibodies post-vaccine are not going to cause severe multi-system inflammatory involvement.
Then mask. There was a question about mask, but Winsley has put up in his slide. Winsley, you would like to re-emphasize on that, about which age we can use mask?
So, I mean, anybody above 2 years of age, you can use a mask. So between 2 and 5 years, you should, I mean, if they can tolerate a mask, you can use it. So yeah, so that's the age cutoff, I guess. Less than 2, then it's not good for them to use a mask.
Another question about MIS-C in adults or adolescent. Yes, they are. Even in our ICUs, in our medical ICU, they are. Even in adults, they are thinking about that presentation like MIS-C. But clear-cut papers, I'm not very sure about that.
So last week I was attending a rheumatology meeting in the adult rheumatology. They say MIS-C they see in adults also, but the presentation is more of shock, not like KD-like presentation. They are seeing MIS-C in adults also.
Right, but they are during the acute COVID itself, they are seeing more, not later, I think so, right? That's during the, but there they can differentiate the cytokine storm as well as this MIS-C presentation.
Exactly.
They are getting better.
And
then after some time, they are developing a shock like picture with inflammatory markers are going high. And that time they are giving IVIG again. And, yes. How long to give this aspirin?
So aspirin is very clear. So we said low dose aspirin, especially for Kawasaki phenotype or thrombocytosis or coronary artery involvement during the time, or somebody has got severe LV dysfunction also. We give aspirin for 6 to 8 weeks. When the echo is normal at 6 to 8 weeks, we stop. Suppose echo still shows coronary artery dilatation is there, we continue the low dose aspirin like Kawasaki-like disease till the echo becomes normal.
Yeah, even in ICU we don't give, but they may have platelets low and other problems. And especially when there is a coronary or the ejection fraction is very low, we can think about anticoagulants as prophylactic, but otherwise we don't routinely use it. Dexamethasone, a usual question for Satish. Dexamethasone or methylphenidate, which is better?
So which is better? So we all know everything is steroid, all works in the same principle. Only thing how severe, how fast it acts. See, as a pediatricians, remember that we don't use dexamethasone routinely because dexamethasone is a very high glucocorticoid potency. It causes lot of HP axis suppression, growth inhibition. So we don't use DEXA. The DEXA came into picture because the adult COVID, they used DEXA in the both the trials, recovery trial and the solitary trial. That's why the DEXA came initially. But now when you look into all the guidelines, Indian guidelines or every guidelines, nobody says DEXA now. Everybody says methylprednisolone, 1 to 2 milligram if the child needs IV, oral prednisolone if the child is going home. So dexamethasone doesn't have any big advantage, but it is more harm. Actually, the side effects are more compared to the methylprednisolone. So try to use methylprednisolone and dexa. Yeah.
Is prophylactic oral anticoagulant indicated post-COVID? Is it talking about acute COVID or in MIS-C? I'm not sure. Is prophylactic oral anticoagulant?
There is actually no role for
No role,
prophylactic. Yeah, anticoagulant.
And there is another question about, I missed it. Where is that? When to start steroids in COVID positive children?
So again, steroids, we said no, what phenotype? So febrile inflammatory state, Kawasaki disease, and in severe shock. Febrile inflammatory state, we wait for 2-3 days. Sometimes they settle by itself. The fever is not settling. We have ruled out all the infections. Common infection, till the CRP is high, blood culture is negative. You think this child has got only like febrile inflammatory state, we can give steroids to 1 to 2 milligram for 5 days, not more than that. But other children, when they come into the ICU, we already told the protocol. We give based on the severity of the disease, whether we give 2 milligram or 10 milligram per kg, total duration 2 to 3 weeks. Most of the time, first week, they'll be in the ICU, they'll be getting the methylprednisolone. When they go home, we'll send them home. 1 week later, when they come, we'll repeat the parameters. If it is normal, next another 2 weeks, we'll stop the prednisolone. So maximum duration is about 3 to 4 weeks.
What percentage of children recover after mild MIS-C? So 100% they should recover.
Yes.
What? See, we have seen this wave, about 32 patients till now. We lost only one child who had got a comorbidity, plus he went into severe HLH type. So recognizing appropriately and starting the treatment is important. Then the percentage of the mortality will be very less, right? Sadish, what do you want to say?
Yeah. See, well, however sick they have come, if they come very early, it's very easy. If they come very sick, very severe, shock for 2-3 days, not treated properly, then it's going to be a difficult one. If you recognize, that's what the whole idea of this CME is, to have early recognition only.
Yes.
Think of MIS-C. But remember that, rule out all the other common conditions. Again, MIS-C, we are going to see only for the next 2 months. Once this COVID wave, unless the next COVID wave comes, the MIS-C is going to go down.
And at appropriately referring when the child is in shock, because early steroids in shock prevents going for a life-threatening or a severe myocardial dysfunction. That is really our experience. So timely intervention with steroids or IVIG might improve. So another one is about G6PD. In a known G6PD individual, if they get MIS-C, can we give aspirin?
Is it aspirin contraindicated in G6PD deficiency? I'm not sure about that. Anybody knows? Is aspirin contraindicated in G6PD?
I don't think so. Winsley, any idea?
I just looked it up. It's not an absolute contraindication. It's a relative contraindication. I mean, but they've sort of used it in adults where, like post-coronary artery disease, they've used low-dose aspirin and they don't think of it as a definite contraindication. So maybe we can use it.
Yeah, we can use it.
Yeah. Is there follow-up studies for children with COVID, post-COVID?
So MISC, there is 2 studies which is published this week in the NEGM. Okay, there are follow-up studies of MIS-C itself. Obviously, the other COVID infection children, they should have follow-up.
No, so there's actually more follow-up studies with MIS-C than with ordinary COVID. There are some studies, not as much as the follow-up with MIS-C. And like I mentioned, long COVID, has not even been followed up or investigated. So that is the unfortunate situation for follow-up with COVID. There's one more question on flu vaccine and COVID protection.
COVID, yeah, that's
And the answer is no, flu vaccine does not protect against COVID.
So this IVIG and this methylprednisolone in limited resource settings. See, that's what the protocols have come. I know it is a difficult situation if you have to give IVIG. Satish may know about that. Today there was attending on JAG. In Chennai, there is scarcity of getting IVIG, it seems. Is it?
Yeah.
10 grams and all. Huh?
The people are getting IVIG and keeping at home. That's also happening. So that's what happened last time.
What is happening? Yeah.
Everybody,
Yeah.
remdesivir happened last time in adult COVID.
Yes. But the answer to that is, as Satish has already said, Kawasaki phenotype.
Yes.
And severe variety, yes, IVIG, right. But if you don't have methylprednisolone 10 to 30 mg per kg, that also can help.
See, yesterday 2 days back, we had a webinar with Kerala. Kerala, we are talking about the MESSI. Their Kerala protocol is to give methylprednisolone 30 mg per kg on day 1. If they don't respond, only second line is going to be IVIG. That is the Kerala protocol. Because same problem of non-affordability, and it may soon land up in non-availability also.
Yeah, so that is wisely, but it can, methylprednisolone can work, but we have to select the phenotype. That is what is very important probably. Is there any other question? Neonatal COVID. I don't think that we don't have much of problems. Now, Satish, you talked to Sridhar.
Yeah,
right?
so there are see, newborn is managed by our neonatology department. They told me 2 children they have who had some respiratory distress and which all settled with IVIG. They didn't have anything very significant numbers there.
Vaccine is, if we start the prevention strategies, can we avoid the third wave? Winsley, want to answer?
So, I mean, as long as we follow distancing, masking and everything, there will be lesser number of people with COVID. But the moment that gets relaxed, there will be a little bit of an increase. If we get ourselves vaccinated, and if the population gets vaccinated by the time we relax our these social measures, then I think we can avoid the third wave. But otherwise, it's going to be very difficult, because as we relax all our distancing and masking and everything, and if the population is also not vaccinated, there may be a increase, and that, I mean, like a third wave. Also, we don't know what will happen with variants emerging. Like, whether as the variants emerge, how much of pre-existing immunity will prevent a particular variant from establishing disease. That information we don't know yet. So, I mean, a lot of it is speculation. So it is possible that there could be a third wave, but definitely if we use the social measures, we can definitely, I don't know whether we can prevent, but we can delay a third wave with vaccination by the time we go to
Another
the
question, which vaccine is safe for all age group? But Dr. Wilson also mentioned in his talk.
Right now, there is no vaccine which is available for use in children. So there is no question of which vaccine, because none of these are actually been studied in children. So we'll have to wait for these results. Right now, what we know is the safe vaccine is actually using the Pfizer vaccine, which are all these mRNA vaccines. So they are safe in children, but we don't have access to those vaccines yet. So, but with regards to Covaxin and Covishield, we'll probably have to wait a little more till we get information from those studies.
I want to add on one thing. The incidence of anaphylaxis and clots with Covishield, I think Winsley pointed that out, is basically 1 in 500,000 to 1 in a million. And if you look at the incidence of anaphylaxis with DPT, ordinary DPT, which we drag all our children and take, that is also 1 in a million. So, I think I'm not even sure whether we will get Pfizer vaccine. I would say whichever vaccine we have, we should take. The risk of anaphylaxis and other serious complications is so much less compared to the risk of mortality and other disease due to the disease itself.
Thank you. So there's another question. Just put oxygen therapy. I'm not sure what they want to ask about oxygen therapy in children, but you need to remember 94% is the cutoff. We'll say hypoxia less than that. In ARDS only, when in ICU, we accept a saturation of 88 to 92%. And other than 94, and accordingly, we can use low flow or a high flow oxygen devices. I think we have come to the end probably. Is there any other question? No.
You follow these children, sir, after COVID, after admission when they go back? Are there any studies to follow them? Follow them up?
Yeah, the missy children we are planning to follow. About other, is there any study we have, Nelson?
She also knows Roshni is looking at antibody persistence, so she will have some follow-up data.
Also, there is some study looking at lung function after COVID and all that, I think.
Yeah.
There is a question on criteria for admission. In acute COVID, you want to answer?
Sure.
Criteria for admission for missy.
Missy, all the missy to be admitted. If you suspect missy, even if it is febrile inflammatory state, we have to admit and monitor them. We cannot manage as OPD because these children can sometimes go into shock and all. So all the missy, whether mild, moderate or severe, has to be admitted.
Yeah, so that I think probably our state government also will make come. Or I think we heard from Kerala, they have made it as a reportable disease, and even they have developed some tool to identify and referral earlier, right? Using the ASHA, Anganwadi workers and other people.
Otherwise, for us, I think all the government protocols for non-missy COVID is tachypnea, admit for observation. That's the criterion for children.
Yeah, so for children, I think that if you follow even IMNC protocol,
yeah,
when the traffic light things, very clearly in any medical practitioner when to refer and when to get admitted, the danger signs informing the parents. That will hold good for all, even in acute COVID and for missy as well. But missy, probably we may have to have a high index of suspicion when you have this Kawasaki or a rash with conjunctival congestion.
There's one question on awake proning for you, Ebor.
Awake proning, older children, yes. About older children, in the sense when they are intubated for any age group, we do that. And you are talking about awake proning for non-invasive ventilation. We use milder sedation like dexmedetomidine or some sort of trichloride, something very difficult in infants. We tried, but Wilson asked me this question recently, and we tried for one of the child with 15 months old, or not 15 even, 12 months old. And it worked actually for some time, but eventually we have to intubate. But awake proning, it's maybe difficult in younger children unless we use some anxiolytics or sedatives.
So in practice, when we see children, when do we advise this RT-PCR? So sir specifically told RT-PCR when they are in need of admission, we do that. But otherwise, in practice, we see a lot of cases with the same symptoms like URI, sore throat, and without history of any contact with an adult COVID also. So in those cases, what we tell now is we say you isolate them from the elders of the family and give them good food, nutrition, and also only paracetamol and tepid. And then in case some adult in the family gets it, for them also paracetamol for 2 days, and third day let them get a PCR, that RT-PCR test. That's what we tell them. But about the children, when do we advise like any specific?
Exactly what you said, ma'am. That is, if there's someone in the family with COVID, then they consider that it is COVID. We would prefer that they give their PCR after day 3. And interestingly enough, a lot of children actually end up with, become asymptomatic by day 3. So, so if there's someone in the family who's positive, normally the ASHA worker will come in, or the field worker will come in and isolate them and make sure that they are all tested. But for the child, exactly what you said is correct. If there is no history of contact, then we would probably just tell them stay at home, isolate, and wait and see. I think, that's much more reasonable than, doing RT-PCR for every URL.
Yes. Thank you, sir.
It's a question of mucormycosis in children. Alson.
Yeah, sure.
Probably recently, not in COVID, we had recently 3 patients with mucormycosis, but they all had other different comorbid, not because of COVID, DKA, and one child with leukemia and chemotherapy.
There has been 1 or 2 case reports, but it doesn't seem to have been a major problem. In children, we've not seen COVID positive mucor in the ICU during this wave. So again, what are the reasons for that? One is a lot of children are not on chronic, long-term steroid therapy. We do see mucor in children with leukemia on immunosuppressant drugs. So that is actually more of a driver for mucor than COVID currently.
Yeah, thanks, Wilson. RT-PCR from what age is recommended?
RT-PCR from any age is recommended. In fact, newborn baby RT-PCRs, if you're thinking, you can do it on day 1, day 2, or day 3. There's no particular age at which you can do an RT-PCR. You just need a proper sample, and that is the issue.
Yeah.
There's one question.
Missy, can Missy be diagnosed when both RT-PCR and antibodies negative, but a child has got a fever? That will become a Kawasaki, right? Again.
So
it will know history of contact.
History of contacts. Remember now in this pandemic, now this stage, every child is exposed to somebody in with the COVID. So if the clinical syndrome is typically like Missy, don't worry if it is negative, I don't treat. But remember that if it is negative, make sure you ruled out infection, everything before you start treating. If they come with KD phenotype,
yes, that is very important. Yes.
So if the antibody is positive, it gives one more thing. Okay, it could be thing, and we can, especially steroids. I will always tell Ebar Jacob and Winsley may not agree. IVIG will not harm the patient. IVIG will harm the parents' father's packet because of the cost. Even if it is infection, IVIG may help.
But it will take time, So by the time it comes to ICU, whether you give a low dose steroids, or that's what we prefer, a low dose steroids if they are in a milder form of shock, rather than IVIG, because in ICU we closely monitor them. We'll see the response and do. But then if all are negative and if they have the inflammatory markers high, that will come into the febrile inflammatory group as well. So you may not jump and start steroids, or what do you do?
If the child is sick, definitely steroids. If the child is not sick and only inflammatory markers are high, where COVID antibody is negative, RT-PCR is negative, we can wait and watch. Sometimes it will settle.
But they need to be observed closely. They need to be hospitalized.
Last week we had one of our staff child, 11 months old child, 5 days of fever, they came, no focus, ESR high, CRP high, both antibody negative, RT-PCR negative. We did ultrasound, make sure that we ruled out all the infections, Vidal, wheel fillings, everything negative. Even the repeat blood culture came as negative. So whether to give steroids or not give steroids. Child, next day the child became afebrile and went home. Only close monitoring is necessary. But ICU child, if symptoms,
Go ahead.
Yeah, no. If the child is in ICU, even with RT-PCR negative, the child and COVID antibody negative, if you ruled out infections, at least low dose steroids, definitely we have to give.
So that's what we do.
Yeah.
So in this, because it's temporarily associated with COVID period, we may not be using like that in a different situation or season. So in what day from onset IVIG is effective? Till what day?
Till what day from my
What is
onset IVIG? I didn't understand the question, but IVIG will take 24 hours to work. It won't work like steroid. Steroid is the one which immediately works. That's why even if you decided to give IVIG and steroids, we give always steroids first in ICU.
In MIC, have you experienced any anaphylaxis reaction?
No, that's the last question, I think. In CMC, last question. In CMC,
have you experienced vaccination against COVID? Okay.
So the answer is no. And the reason this has come up is, I think, the very first case of documented anaphylaxis came out just last week. And the thing to remember is risk 1 in 100 to 1 in a 10 lakh population. So the take home message for this is, if you're ever advising vaccination, please do it in a good center, 30 minutes observation period, and in a place where, although the risk is so minimal, that if anaphylaxis, like all of us would have experienced with penicillin injection in the old days, where you at least have an adrenaline for resuscitation. So I think that is the only, it's not that anaphylaxis does not exist. The risk is 1 in 10 lakhs, but you should be in a good center, not walk in, take your vaccine, walk out immediately. It should be a center where at least, so one thing we do in CMCs, we have an observation area, we have nurses, we have doctors posted, at least someone who can recognize and treat an anaphylaxis. That is what one should do.
Thank you. I think there is no further question. Probably we'll wind up. Thank you, Dr. Wilson, Dr. Satish, and Dr. Winsley Rose for the brilliant talks and answering all the questions. And it's been a great pleasure. Thanks, IMA Ranipet and Dr. Geeta Alexander and team. And as we know that message we have sent clearly, I hope so, and about overview of COVID, and Dr. Wilson talked about the pathogens, management, manifestation, everything, and about the burden of the impact and our experience. Dr. Rose talked about the prevention strategies. And the important thing probably at this situation is the mystery, which post second wave peak we are experiencing. And it may be rare, but it can be a life-threatening. That's what the important message, and information to the parents and the awareness among the public should be there, and they should be referred appropriate time and the appropriate usage of steroids and IVIG. And I acknowledge the presence of Dr. Manimaran, the Deputy Director of Health Service. He's been there till now. Thank you, sir. And also Dr. Mahadevan, and former professor and director from JIPMER is here. Thank you, sir, for your presence, and all others. Over to Dr. Geeta.
Thank you, the entire team from it was a very wonderful session indeed, and it was very informative, and also it's the need of the hour, and I'm sure all of us enjoyed it, and I hope all the doctors had their doubts also cleared. Though we are all still, there are so many theories coming up about the COVID, and thank you so much, sir, for everything. And just a small word, is Dr. Manimaran, sir, would you like to say a few words, sir? Dr. Manimaran, sir? Sir, you are there, sir?
Good evening, all of you.
Good evening, sir.
Thank you for inviting me and honor me. All the speakers are giving more information about prevention, control, and treatment. I request all of them for training our doctors, staffs, and others during the third wave. Thank you very much for all of you.
Thank you, sir. Thank you so much, sir. And
Thank
now,
you, sir.
There is one question, probably, sorry to interrupt, it may be quite important. So Satish, you want to answer what to do when and repeat echo after a week shows increase in diameter of coronaries?
So what we'll do is, if the week you give an IVIG, we go by the clinical things. So if 1 week later you send the child home on aspirin, and the child comes back with a repeat echo is showing mild increase in the coronaries, so we look for the inflammatory parameters. The child's fever, ESR, CRP. If it is high, and we have to augment the therapy with infliximab. If the second week echo shows increase in the coronary size, the ESR CRP is also normal, we have to give infliximab to stop the progression of the coronary artery involvement.
So that is the take by the rheumatologist to give this IVIG. Kawasaki, that's what we have phenotypically categorized them clearly. Kawasaki phenotype is obviously we need to give IVIG to prevent this problem. And even in severe MIS-C, about 20% they have reported coronary involvement. That's the debate of giving IVIG and the upfront in severe varieties of MIS-C, severe shock.
See, the MIS-C, we are still learning. You know, the whole analogy of MIS-C is come from Kawasaki disease, the post-inflammatory SARS-CoV-2 inducing your immune system and causing this post-inflammatory state. So the treatment of Kawasaki disease is IVIG. IVIG is the standard of care. That's why they want to give IVIG for everything. But somebody comes with only with shock, no cardiac involvement. Most of our patients settle with low dose steroids. We don't use IVIG for them.
Absolutely. So that's what we are still learning. Having said that, we have got 17 patients from our old first wave, and we have given about 44% of them only received IVIG. Others just were given steroids, they went on. Well.
And there is a retrospective study published in NEJM yesterday, and they found out they collected almost 600 patients. There is a retrospective MISC patients. They didn't find any difference between the people who received only IVIG and steroids, or steroids alone. There is no big difference in the immediate mortality and morbidity, immediate. But the long-term things, we have to follow the children and see.
Thank you. Sorry to interrupt, and over to Dr. Geeta.
Thank you, sir. And now for the vote of thanks by our Finance Secretary, Dr. Srinivasan. Dr. Srinivasan?
Yes, ma'am. Good evening, ma'am. Good evening, all once again. And I thank our speakers, Dr. Wilson Philip Varghese sir, Dr. T. Satish Kumar, Dr. Winsley Rose sir, and Dr. Eber Jacob for excellent educational feast for us. It was very much useful for us for all our practice. Thank you very much, sir. Thank you for spending your valuable time. And I thank Dr. V. Manimaran sir for supporting us by participating in this program. Thank you so much, sir. I thank all the participants. It was very good response from all of you. Thank you very much for your support. Thank you all. Yes.
Thank you so much, each one of you. And thank everybody.
Thank you.
Thank you very much for having us. It was an absolute pleasure. Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you.
Nice to see you, Mahadevan sir.